So good evening. Thank you very much to David for this invitation. I'm Dr. Esteban Emiliani from Fundació Puigvert in Barcelona, and I'm going to share with you a case that we have regarding the use of potassium citrate in uric acid stones, which we think is very, very crucial for the treatment of this kind of disease. So this was an 89-year-old male patient. He has recurrent left colic pain and hematuria. He was seen in another hospital. He has a history of metabolic syndrome, which is very, very typical for uric acid stones, diabetes, hypertension, dyslipidemia, and hyperuricemia. So he had all the risk factors for uric acid stone. So the patient also had a severe autoimmune pancytopenia and a poor response to treatments. So this made the patient very fragile for any kind of intervention. He has congestive heart failure with low ejection fraction, and he was referred to our center because he could not undergo surgery in another hospital. This was the patient kidney stone on the CT scan. It was a 3-centimeter pelvic stone of 400 ounce-fill units. So in the other hospital, they wanted to do a PCNL. Remember that the PCNL is the first treatment for this kind of stone, but it was actually referred to our hospital. The physical examination was normal, the urinary pH was 5, and the glomerular filtration rate was normal. So as I said before, the PCNL is a first-line treatment option for 3-centimeter kidney stones, but this patient was ASA score 4, extremely high surgical risk. And in the other hospital, the anesthesiologists were against surgery, and the urologist didn't also want to perform the surgery in this very high-risk patient. So we had a patient with a 400 Hounsfield unit stone and a urinary pH of 5. So those are the red flags to think about uric acid stones, as I said before. So this patient had a uric acid stone, and the first thing we did was not to think about surgery. We thought about chemical dissolution of this stone. So for this, we used the lead control pH up 3 times a day for 3 months, which is our standard procedure for patients with uric acid stone, especially before surgery. This medication, the lead control pH up, has potassium citrate, magnesium citrate, and theobromine. We have to remember that the EAU guidelines recommend urinary alkalinization for uric acid stone, and the level and the threshold of urinary pH needed for the treatment of uric acid stones is 6.5. If you want to prevent stones, the threshold will be 6.2, but for treatment it will be even higher, 6.5, and this is what we got with giving the patient 3 times a day lead control pH up. So the other good thing about the lead control pH up is that it includes theobromine, and there's countless of papers and evidence demonstrating that theobromine dissolutes, or it's good for the inhibition of crystals of uric acid. So it's another extra component that helps the potassium citrate to avoid the crystallization of uric acid and to increase also the urinary pH to avoid this crystallization. So at the end of the 3 months, we repeated the CT scan, and as you can see here in the CT scan, it was completely dissoluted. It was a complete dissolution of the stone, and the patient, ASA4 and high-risk patient, did not need any kind of surgery. So remember, uric acid patients need urinary alkalinization always as a first treatment option, and this is what we do routinely in our center. We never operate directly to the patient. We always give lead control pH up with 3 times a day for 3 months and reassess the patient. And some of them will disintegrate the stone for completely. And then we give lifelong medication. We recommend lifelong medication to avoid any recurrence. And we want to keep this pH above 6.2, especially to ensure more than 5.5 and 5, which is usually the uric acid stone pH, but we want to reach that 6.2 to avoid recurrences. And that was it. And this is our case for today. It's a very simple case, a very important case, just to remind us which are the best steps to treat kidney stones, especially uric acid stones. Thank you very much.